That's a funny one. Just for fun. Good afternoon, everybody. Just let others get in. Hi, my name is Chris, and I'll be co-chairing this session with my friend and colleague, Shade Hendricks, next to me. Welcome to this afternoon's wellness session. I hope you are as excited about the program and the topics that we're about to discuss as I am. The housekeeping rules, still the same as any other time, just to remember to keep your phone on silent or to switch it off if you can, please. And just to remember to scan for your CPD points outside. So without further ado, I would like to invite our first speaker to the stage. That's Dr. Keelan Key. She is an anesthesiologist at Charles de Gaulle Pediatric University Hospital. I hope I said that correctly. She is also the associate professor at the Joseph Key Zebo University in Ouagadougou in Burkina Faso. Thank you. Welcome, Dr. Key, and we're looking forward to your talk.
Thank you. Good afternoon, everyone. It is my honor to share with you about this topic, but first I would like to say thank to the local committee organizer to have invited me for this meeting. So sorry, I'm French speaker, so I will continue in French, but the slides are in English. Donc, nous allons parler de ce thème qui est, s'agit-il du canari malade de la mine de charbon, parlant des causes du burn-out en 2024. On va commencer par rappeler donc le lien entre le canari et le charbon de mine. C'est qu'avant les années 1900, au début du 19e siècle du moins, il était fréquent d'assister à des explosions dans les mines de charbon. Ceci du fait de la présence donc de méthane dans ces mines. Et le méthane étant un gaz incolore, inodore, il n'y avait pas de moyen pour le détecter. Et la pire catastrophe qui est intervenue, c'était au Japon avec un peu plus de 40 000 victimes. Un autre gaz qui était dangereux dans les mines de charbon, c'était le monoxyde de carbone, également inodore, incolore. Et pendant longtemps, le canari et d'autres types d'oiseaux ont été utilisés donc pour pouvoir détecter les risques d'explosion et également d'asphyxie par le monoxyde de carbone. Les miniers amenaient les canaris dans les mines et lorsque le canari commençait à battre des ailes, à se sentir mal ou décédait, on savait que le taux de monoxyde de carbone était important et il fallait quitter la mine pour éviter la catastrophe. Quel lien avec les causes du burn-out entre le canari malade et les causes du burn-out? On va commencer par définir le burn-out. À retenir que les définitions ont varié avec le temps. La première définition a été donnée en 1970 par Freudenberger, qui caractérisait le burn-out comme un état d'épuisement résultant de conditions de travail difficiles. En 2001, Malache va donner une définition qui est que le burn-out est un syndrome relatif aux problèmes en lien avec le travail et qui comportait 3 éléments, l'épuisement, le cynisme et le sens réduit d'efficacité au travail. Et enfin, une définition qui a été donnée en 2021 qui se veut être beaucoup plus harmonisée, qui est que le burn-out est un épuisement physique et psychologique dû à une longue exposition donc à des conditions de travail difficiles. Comment on en arrive au burn-out? C'est que l'employé est confronté à des situations difficiles, il ne trouve pas les ressources nécessaires pour venir au bout de ces difficultés et finit donc par s'épuiser aussi bien physiquement que moralement. Et comment cela s'explique? C'est que dans les services, il y a des guidelines, il y a des manières de faire qui ne collent pas toujours avec la réalité. Si je me rapporte aux agents de santé, on peut être devant un malade qui est diabétique, on sait comment soigner le diabète, mais il est en plus insuffisant rénal et il n'a aucun moyen financier pour se prendre en charge. Ça, ce n'est prescrit nulle part comment je dois prendre en charge un patient qui est pauvre. Donc, ça demande de puiser dans ses ressources donc, pour pouvoir venir à bout des difficultés qu'on rencontre. Les causes du burn-out, il y en a énormément, mais on les a réparties en 3 grands groupes. Les causes en lien, effectivement, avec le travail, les causes en lien avec l'employé et les causes en lien avec la société, et c'est ce que nous allons dérouler. Les causes en lien avec le travail, c'est le travail qui est dur en termes de temps, qui nous demande de passer beaucoup de temps sur le lieu de travail, mais le travail qui est dur en termes d'intensité et d'exigence. Un chef de service n'aura pas les mêmes attentes vis-à-vis de lui que le subalterne. Le manque d'autonomie au travail, quand on n'a pas la latitude de faire ce qu'on veut, mais que tout doit être protocolé, je ne peux pas bouger de ce qui a été défini par le service, ça peut être cause de burn-out. Le manque de motivation, que ce soit intrinsèque ou pas, parce qu'ils ne répondent pas à nos attentes, ou l'absence complète de reconnaissance. La mauvaise ambiance de travail, quand on n'est pas sociable, on n'est pas cordial sur le lieu de travail, mais au contraire, on se lance des pics, on est très désagréable, ça peut conduire au burn-out. Le manque d'équité et de respect. Si le chef de service ou le responsable traite différemment certains agents en les brimant, ça peut conduire au burn-out. Et enfin, c'est le manque de concordance entre nos valeurs personnelles et les valeurs prônées par le service. À titre d'exemple, pour les agents de santé, si vous vous retrouvez dans un service qui prône l'euthanasie, alors que votre morale ne le permet pas, ça crée un conflit que vous allez devoir gérer. Donc, après ces causes en lien avec le travail, on a les causes individuelles. Et comme marqué ici, ces causes individuelles semblent jouer une part importante dans la survenue du burn-out. Et comme cause, donc, c'est le haut niveau de neurosisme. Le neurosisme, c'est le fait d'être péjoratif, d'être pessimiste, de voir tout en noir, d'être introverti, d'avoir peu de conscience professionnelle, d'être désagréable. Ça peut conduire au burn-out. L'expérience professionnelle, pour dire que lorsqu'on a une grande expérience professionnelle, ceci nous permet, face à des difficultés, de puiser dans notre expérience et pouvoir résoudre des problèmes. Mais quand on n'a pas cette expérience, on est confronté à l'échec qui va conduire donc au burn-out. Et il y a également la responsabilité. Je parlais tantôt du responsable de service et du brancardier. Ce ne sont pas les mêmes responsabilités, donc ça ne sera pas le même stress qu'on va porter. Il y a le faible niveau d'estime de soi et également notre perception, ce que nous attendons de nous-mêmes. Lorsqu'on est trop exigeant envers soi-même, ça peut constituer un facteur de risque. Et le style de vie. Donc, le style de vie idéal, c'est d'avoir un bon temps de sommeil, des activités sportives, une alimentation équilibrée. Et lorsqu'on n'est pas dans ça, le risque, donc, c'est d'aller vers le burn-out. Enfin, troisième groupe de situations qui exposent au burn-out, ce sont les situations en lien avec la société. Et là, il faut mettre un accent particulier sur les nouvelles technologies. On parle de l'intelligence artificielle. Ça peut créer la peur de perdre son emploi. Il n'y a plus de barrières. On est joignable partout. Donc, il n'y a plus de limite entre la vie privée et le service. Donc, on a de la pression du travail à tout moment, sans plus de restrictions, sauf si on doit obéir à certaines lois. On est également dans un monde de compétition, d'auto-emploi, et lorsqu'on crée son entreprise, la hantise, c'est d'échouer. Et donc, si on a cette hantise-là, ça va créer un stress. Et enfin, les conflits de rôle. On n'est pas seulement qu'employé, on est parent, on fait partie d'associations caritatives, etc. Et tout ceci, toutes ces activités donc, peuvent créer des situations conflictuelles. Voilà, on est à Johannesburg et la famille est de notre côté et ça peut créer donc des situations difficiles à gérer. Donc, lorsque ces causes sont présentes, qu'on n'a pas pu les gérer, qu'on en arrive au burn-out, donc qu'est-ce qui va se passer, autrement dit, quelles sont les conséquences de la non prise en charge des causes. C'est, comme on l'a dit, les manifestations. Bon, dans un premier temps, on retient que ça apparaît de manière séquentielle. Et la première manifestation, donc, ça sera l'épuisement. L'épuisement moral, l'épuisement psychologique, en lien donc avec le fait qu'on a échoué dans la gestion de nos stress. Et comme manifestation physique et psychologique, on a vraiment une destruction sur le plan émotionnel. On a explosé tout ce qui est sentiment négatif, la peur, l'irritabilité, la nervosité. Et à côté de ça, il y a des dysfonctions ou des pathologies somatiques, les maux de tête, les maux de ventre, etc., les infections, les idées suicidaires et des comportements addictifs. Donc, celui qui est confronté au burn-out aura tendance à la fin de son activité journalière de recourir à des produits illicites, pas forcément, mais à des substances voilà, pour pouvoir tenir, donc telles que l'alcool et la drogue. L'employé confronté donc à l'épuisement psychologique et physique va finir par entrer dans la phase de cynisme, qui est de se retirer émotionnellement. Donc pour le prestataire de santé, il sera moins empathique vis-à-vis de son patient. Donc on doit soigner le patient, mais vous voyez ici cette infirmière qui est assise. Donc pour dire que la douleur ou les attentes du patient ne l'intéressent pas autant que ça, il se replie sur lui-même. Et vous avez le monsieur, lui, qui est sur son ordinateur, mais au lieu de travailler, il est en train de dormir. Et la troisième étape, c'est que l'épuisement, le cynisme vont amener l'employé à détester le travail, à se dire « ce travail, je n'arrive pas à bien le faire, je n'en suis pas capable, c'en est trop ». Et voilà, c'est le burn-out, comme on l'a dit. Donc, lorsqu'on est dans le burn-out, le travail qui initialement était quelque chose qui fait du bien, qu'on attendait, qui était censé nous apporter une certaine satisfaction, devient un poids. Donc, on ne tient plus, on s'effondre et c'est difficile de se relever donc après le burn-out. Donc, pour terminer, est-ce que, et du moins, au-delà des conséquences individuelles, il y a des répercussions qui vont au-delà de l'individu. Donc, je disais tantôt, l'employé qui est dans son cynisme, il va moins bien prendre en charge ceux qui sont en face de lui, les clients. Et pour les agents de santé, la sécurité des soins ou l'efficacité des soins va prendre un coup. L'agent qui est obligé de s'absenter pendant longtemps, il doit être remplacé par ses employeurs. Et donc, ce qui crée un supplément de ressources à trouver pour embaucher de nouvelles personnes, mais également ça constitue un manque à gagner pour l'organisation qui l'emploie. Donc, pour conclure cette partie sur les conséquences du burn-out, c'est dire qu'il a été reconnu que le burn-out est donc une préoccupation sociétale, un problème sociétal qui a des conséquences sévères aussi bien pour les organisations, les services que pour les employés. Donc, pour conclure, je dirais que aussi bien les explosions et les asphyxies dans les mines de charbon que le burn-out sont des situations catastrophiques. Quand l'explosion arrivait dans une mine, parfois il fallait quitter totalement la mine, après avec de nombreux décès. Quand quelqu'un fait son burn-out, il est complètement dévasté et ce n'est pas toujours évident de pouvoir se relever. Parfois, il faut changer carrément de travail. Donc oui, interroger les causes du burn-out serait similaire donc aux canaris malades des mines de charbon parce que, comme le canari qui constituait quelque peu le signe d'alarme quant à l'imminence d'un danger, les causes du burn-out attirent également l'attention sur l'imminence d'une catastrophe. Catastrophe pour l'individu, catastrophe pour les employeurs. Et donc, il faut prendre en charge de manière efficace ou tenir compte des causes du burn-out, les prévenir pour que cela n'arrive pas. Et tenir compte des causes du burn-out, comme on a dit, les causes, il y a plusieurs rubriques. Il faut également appliquer les solutions tenant compte de ces rubriques. Donc, au niveau individuel, il faut cultiver l'estime de soi, la confiance en soi, la capacité à se poser des questions, à se remettre en cause et à chercher à trouver des réponses innovantes. Sur le plan émotionnel, travailler à mieux maîtriser ses émotions et être capable donc de faire face ou de mieux gérer les situations difficiles qui se présentent à nous. Être empathique. On a vu que le fait d'être désagréable n'était pas quelque chose qui nous éloignait du burn-out, au contraire. Donc, il faut essayer d'être agréable et également avoir une bonne hygiène de vie. Donc, je disais, la charge de travail est un problème, mais justement parce que la charge de travail va nous empêcher de dormir, la charge de travail va nous empêcher de pratiquer des activités sportives. Il faut aller au-delà de ça et se donner le temps donc d'avoir un style de vie sain. Au niveau des services, il faut une bonne organisation qui sous-entend de planifier les activités, qui sous-entend de pouvoir prendre des décisions, mais également laisser la latitude aux employés d'en prendre, de savoir motiver les employés. Ce n'est pas seulement la motivation pécuniaire, pas financière, mais pouvoir sur le plan moral encourager les employés, les évaluer. Il faut que les responsables soient de bons leaders. Le bon leader, c'est celui qui sait encourager ses employés, qui sait reprimander sans humilier et qui sait être un soutien. On a parlé de mentor lors des plénières. Le bon leader, c'est celui qui sait être un mentor aussi pour ses employés. Mais quand ces causes ont échoué, ou on sait qu'elles sont très importantes dans notre service, il faut apprendre à dépister le plus tôt possible le burn-out. Parce que plus tôt on va détecter, mieux ça sera plus facile de prendre en charge la personne qui commence son burn-out au lieu d'attendre qu'elle soit à la phase terminale donc de son burn-out. Voilà, je vous remercie pour votre aimable attention et faisons tout pour éviter le burn-out.
Thank you so much. I quite enjoyed what I read. Sorry. I'm going to keep all the questions until the end of the session, so do jot it down if you've got a pressing question, and hopefully we'll have time at the end to get to all of them. Thank you. So our next speaker is Philip Anderson. Philip Anderson is the head of department at Kimberley Hospital. He's passionate about expanding anesthesia knowledge to rural and district levels, and this is happening in the Northern Cape. Philip's going to talk to us today about empathy in an academic department, and I think I'm very excited for this because the proof is in the pudding, and the reputation of Kimberley Hospital's anaesthetic department surpasses itself. I'm sure Philip will tell us that he's got a list as long as his arm of applicants who want to work there. It's like the first place that anybody wants to go to do anaesthetics. So I'm very excited to hear what you can say, Philip, and what I can take home. So thank you.
Thank you. Thank you very much, and thank you, Bertil, for that lovely talk. In your conclusion, you talked about empathy, and I want to pick up from there, if you don't mind. In my first month as a medical officer in anesthesia, I was working in McCord Hospital in Durban. I was in Theatre 2. It was a beautiful sunny day. Theatre 2 had a big glass window overlooking Durban. You could see the sea and the ships out there, and it was going to be the most perfect day at work. And I was doing a cesarean section, and we would mark our syringes with a felt tip pen. And in the UK, they use stickers. We use a felt tip pen. And oxytocin is known as syntocinon, Synto. So we would write Synto on the one syringe, and we would write Sux on the other syringe. And the baby was born, and I in my anxiety and trying to get everything right, turned around, pick up the syringe which had a S something something on it, and I was halfway through injecting the first mil, and I realized that says sucks. And I froze. And I asked the anesthetic nurse, please call Dr. Manny immediately. I was trying to figure out what to do. I had an oxygen mask on the patient, and Dr. Manny came into the theater, and he was able to sort it out completely. And I was standing there thinking, right, now I'm going to get scaled out completely. He's going to report me to the HPCSA. He's going to tell me I can never do anesthetics again. I was really waiting to get absolutely grilled. And he said, well done, Philip. Now you're a real anesthetist. We've all made drug errors, but don't do it again. And I was shown empathy at a very crucial point in my early career. And I have carried that style of leadership throughout my career. And touch wood, not that I don't know of any other drug errors that I've made. So thank you, Dr. Manny, for that. So preparing a topic on wellness is not something I'm used to. I usually talk on physiology or clinical things. But in preparing on wellness, I realized just how important it is. So I thought, well, let me give you my concluding remark. If you are an HOU in an academic department, your primary role is not to take care of the patient. Your primary role is to take care of the doctor who takes care of the patient. And with this perspective in mind, your department will flourish and people will want to work in your department. Two things that a great leader needs. The one is empathy, and the other is perspective. Sometimes as a department head, I can get so caught up in the departmental affairs that I forget what my actual role is. I'm not supposed to be in charge of the department. I'm supposed to care for the people in my charge. If you're a consultant, that means you're a registrar. That means you're a medical officer. If you are in a university hospital, that means you're a consultant who needs to take care of the medical officer or registrar. But we don't often get trained in this. When you were a registrar or a medical officer, all you had to do was be good at your job. You had to learn, you had to show up at work, you had to practice what you were told, and you had to pass your evaluations. And if you were really good at that, then you got promoted and you would become a consultant. If you became really good at that, they would make you a leader. But can I see by show of hands, did anyone here get formal training on how to teach registrars, medical officers, or interns? I'm glad that there's some, but I can also notice that there's very few. Did anyone here get formal training on how to manage intra-departmental conflict? Because I'm glad that there are some, but once again, it's marriage counseling it is? Yes, very good. Yeah. So other than that, there were very few hands that went up. And I think that that's one of the reasons why we get managers in anesthetic departments and not leaders in anesthetic departments. And I also think it's a reason why many consultants micromanage their departments and they want to get involved in everything, because the truth is they actually are better at the job than the person who's learning. When I started as a consultant, I used to micromanage the MOs in the theater, and I would hover over their shoulders and what they call helicopter consulting. And my predecessor, Louis, he said, Philip, how are they ever going to learn if you never give them any freedom? What we need to do when we become a leader in a department is to go through a transition. And for some of us, the transition happens quickly, and for some of us, it happens slowly. And for some of us, it never happens at all. I think one of the problems in South African hospitals is that we aren't being taught how to lead. There are some resources that I've gone through and I highly recommend. There are many resources. I found these very helpful. Dale Carnegie's book, How to Win Friends and Influence People, I've read it 3 times. It's such a good book. And earlier this year, I was down in Cape Town doing the Mediation in Motion course, and I really can't recommend it enough. It is such an incredible course, and I would recommend for everyone who gets the opportunity to go through this. Through resources like these, we can learn leadership. Leadership is like a skill that you can practice and you can get better at it, and it'll grow and it'll make you a stronger leader. But also, like any skill or any muscle, if you don't practice it and you don't exercise it, it'll atrophy and you become a weak leader. Everybody in this room has the capacity to be a leader. Everyone in this room has the capacity to be a parent. And not everyone has the capacity to be a good parent, though, and not everyone wants to be a parent. And equally, we all have the capacity to be a leader, but not everyone wants to be a leader, and not everyone should be a leader. Being a leader comes with great personal sacrifice. It means that when everything goes well, you have to give away all of the credit to your team. And when everything goes wrong, you have to take all of the blame on yourself. When something goes wrong, instead of yelling at the medical officer, you have to say, try again, try it this way. Even though inside you know that you could sort it out yourself and it would possibly even have a better outcome. But the medical officer needs to learn. And the pressure is on you rather than on them to succeed. Great leaders are not responsible for the job. They are responsible for the people who are responsible for the job. As a consultant in an academic hospital, the patient is not always your top priority. The medical officer or the registrar is learning as hard as they can. They are trying to prove their worth to you. They're trying to show you that they can do the job. And that is the reason that you're there, to make sure that they can do that. When I'm on call, I'm on call from home, and most of the patients who are anesthetized, I will never see them or examine them myself. I need to make sure that my medical officers are ready and that they can do that. So during the day, teach as much as you can. During the night, let them have the freedom and take care of them because they are my primary responsibility. So in Kimberley, we've been trying to practice an empathetic approach in our department for the last 10 years. And I must say, I don't always get it right. If I can just ask the technician at the back. Never mind, here we go. I've gone too far here. Can you go back? Thank you very much. I was doing a PMDS assessment. For those not from South Africa, it's like a quarterly assessment that you have to do with the doctors in your department. And for the sake of confidentiality, I'm going to call this lady Sam. I knew Sam as a really hardworking, very brilliant doctor. And I asked her, Sam, what do you think about working in the department? Are you enjoying it? And she said she is happy in her job. And I asked her why. And she said, I really feel that my consultants care for me here. I also knew that in Sam's previous department, she had struggled a lot. She had suffered from burnout. She had a very, very difficult time. And I know that in that department, they received no verbal recognition for the work that they did, nor did they receive much support. And if they made a mistake, they would be absolutely scaled. So she would make mistakes, and then she would hide them, and she would pretend that they didn't happen. And then she had to live with the guilt of the fact that she had made mistakes at work and she was hiding it from a consultant because she didn't want to have to pay the consequences. And she just wanted to get through the day, and she just wanted to go home. And apparently she was not alone in the attitude that she had at work. If we can... Sorry about this. We as consultants or heads of units, we might be quick to criticize the people who work in our departments. And we might say, if I can just get the right people for my department, then my department will thrive. But it isn't only the people, it is also the leadership. If you have a good empathetic leadership, you will have people like Sam in the anesthetic department. And if you have a critical, hierarchical leadership, you will have people like Sam in her previous department. It was the same doctor, but the environment in which she worked turned her from one type of person into a completely different type of person. If your child is struggling at school, you wouldn't say to them, you got a D in maths, either you up your maths mark or you are up for adoption. We would never do that. So how can we say to our medical officers, your performance better improve or you're out of this department? Oh, I've got a problem here. I need to go to the next slide. Thank you. So what is empathy? Well, let me play two scenarios out for you, and you can see which one is more empathetic. You've been late to work every day for 2 weeks. This is your final warning. Otherwise, we're going to have to do a written warning. How inspired is that person going to be to come to work on time tomorrow? What about, you've been late to work every day for 2 weeks. Are you okay? Can I help you? I'm worried about what's going on. That's an empathetic response. I know of a registrar who was on his last written warning for tardiness before the department was going to pursue termination of contract. And one of the consultants in the department had the idea, just test the guy's thyroid functions. And he came back hypothyroid. And they put him on Eltroxin, and he was just as good as all the other registrars. His career was going to come to an end, but they were concerned more about him than they were about the output. Everyone has performance issues at times. Maybe their child is sick. Maybe they are having problems in their marriage. Maybe a parent is dying. Maybe they're just darn lazy. But we don't know. And empathy is being more concerned about the person than about the output. Our world is suffering the side effects of educational systems that are more than 100 years old, and they're bad for people and bad for patients. Authoritarian, hierarchical teaching schemes, humiliating the medical officer in front of their peers to make them learn harder so that they won't mess up next time. But next time, you just make the question more difficult, and they never actually get on top of it. I certainly suffered this when I was a student, but I'm not going to carry it on to the next generation. This is a satirical article I read more than 20 years ago called The Art of Pimping. And it describes two methods that have developed as a backlash to hierarchical authoritarian teaching. The first one is avoidance. And avoidance is broken down into three things. First of all is the eclipse. You sit in the second or third row of the lecture hall, and you make sure your head is directly behind the person in front, and then the consultant won't see you and won't therefore ask you questions. The second one is camouflage, where you sit absolutely dead still, hoping that you won't be noticed. And if that doesn't work, then there's meditation, and this is usually registrars, and what they do is they close their eyes, tilt their head slightly forward, and put the fingertips together to look as if they're in deep thought about what they're being taught. Senior registrars get more advanced, and they have a thing called the muffin technique. Now, what you do with the muffin technique is in the dominant hand, you hold a large muffin, and you have your elbow bent at 90 degrees. And you listen for the question that the consultant is asking. If it sounds like it's going to be difficult, you move the muffin closer to the mouth. And if you think, no, I can answer this one, then you put the muffin away. So that's called the arc. And then if it's going to be an impossible question, you put the muffin in your mouth and you take a bite, because no consultant is going to ask you a question when you've got a mouthful of food. But some consultants don't get the hint, and they might ask you anyway, in which case you pretend to choke, and they won't ask any further questions. So that's the funny part of it aside. A little bit more seriously, if we look at the South African Constitution, Section 1, Point A, the Republic of South Africa is one sovereign democratic state founded on the following values. First one, human dignity, achievement of equality and the advancement of human rights and freedoms. The other thing that runs our country is the Bill of Rights. And the first right that we have, the Bill of Rights, is a cornerstone of our democracy in South Africa, and it enshrines the rights of all people in the country and affirms the democratic values of, number one, human dignity. So if you want to play the game of the authoritarian consultant publicly humiliating your registrar or medical officer in front of their peers, you're playing a very dangerous game. And you're exposing yourself to litigation, to discipline, and maybe even having to publicly apologize to your subordinate. what does it mean then to be vulnerable? Vulnerable isn't about walking around crying and all emotional. Vulnerability means that you can create an environment where someone feels safe enough to say, I don't know what I'm doing. I can't cope with this case. Please, can you help me? Or, I made a mistake. Can you show me what to do? And they can say this and they know that you're not going to criticize them. Nobody would ever admit some of their mistakes in front of certain consultants because they know it'll just paint a target on their back and they will be humiliated. They're scared to admit that they don't know what they're doing. And sometimes I feel that we've created a culture in which people come to work every day and they lie and hide and fake because they don't want to be caught out. Are we asking our next generation of doctors to work, succeed, and build their confidence and overcome their addiction to technology while working in a toxic environment where they're not allowed to mess up? The young generation is not actually difficult to understand. I know we think there's these huge generational gaps, but they aren't. They want to be loved, they want to feel relevant, and they want to know that someone cares. And that is actually the same for all of us. So it isn't a generational thing, it's every single one of us. Empathy will profoundly change the way that you see the world. When you feel valued, you will act like a person of value. A leader doesn't have to be right, and a leader doesn't have to be in charge. A leader has to care for the people in their charge. So in my first month of anesthesia, I gave suxamethonium instead of syntocinon, and I was treated with empathy, and I've carried that through the course of my career. Last year I was on call and I got a phone call at 1:30 in the morning, and it was a medical officer saying, Dr. Anderson, the patient in maternity is having an anaphylactic reaction to Kefzol. Within 10 minutes I was in the theater and I noticed that the blood pressure was 240 systolic. And I asked, what happened? Terrified, she said to me, I gave the wrong syringe of adrenaline. And I said to her, well done. It took you a year longer than it took me to make that same mistake. You're going to be a better doctor than me. But don't ever do it again. Thank you.
Thank you very much, Philip. That was a great talk. I'm sure there'll be lots of comments or questions, but we'll keep those for the end. I like your tie, by the way. We need to get you a matching Speedo and socks. Our next speaker, she needs no introduction. It's Professor Chris Landgren. She's a clinician, researcher, teacher, mentor. She does it all, and she still continues to shine the torch bright for anesthesia, SASA, and medicine globally. So she's going to talk to us today about the aging anesthetist. Welcome, Prof, and thank you.
Thank you very much. Thanks. Good afternoon, colleagues. I drew the short straw on the. I am on the LOC for this Congress, and I suppose I'm the oldest, so I drew this straw. And in fact, the aging anesthetist hasn't always been my interest, but fatigue in anesthetists was an interest of mine when I was HOD at Barrow quite a few years ago. And it's interesting, but the AAGBI has published amazing stuff and guidelines on fatigue and its role in our wellness. But anyway, as I say, I drew the short straw. Before I start, I just want to say to Philip that if I can encourage, if people would like to lead, if you're a consultant and you feel you'd like to be a leader, the World Federation of Societies of Anesthesiologists has got an incredible mentorship program that they introduced earlier this year. And if anybody's keen, I urge you to go onto the WFSA website and join the program, either as a mentor or a mentee, because there are a lot of people that subscribe to it. So I've called this the aging anesthetist. are we a liability? And I'm an aged anaesthetist, although I don't do clinical anesthesia anymore. Are we a liability or are we a wealth of experience? And at the end of my lecture, you can decide. And who are we referring to? And what's quite scary when you start reading the aging anaesthetist literature is a definition in Canada, the USA, and the UK of an older anaesthetist, not aging, older anaesthetist, is an anaesthetist who is between 55 and 70. So anybody sitting in the audience who's 55 and older and thinks you're a spring chicken, that's not what's in the literature. Are there issues? Yes, there are issues. And it's very hard getting to a certain age and your country has compulsory retirement policies, and a year before you're going to get to that age, you get a phone call from HR to say, have you completed your retirement forms? And there's kind of a countdown from HR of when you're going to retire. This is in the state, obviously the private sector is different. And it really gets driven into you that you've now got to the end of the road. And it's hard. Personally, it's hard, and because you kind of get this label, a has-been. And I don't believe that at all. And it's 6 years since I was forced to retire from Wits and Barra, as they have the same policy. And I've kept myself busy doing an awful lot of, I hope, useful things. And I'm very busy. But there are issues. And first of all, there are workforce issues world over, and most of the literature that I found when preparing for this topic is Canada, USA, UK, and Europe. I struggled. ANSCO, the Australian Society, has very kind of vague guidelines that apply to all clinicians. So those are the only references that are readily available. There are patient safety and litigation issues. There's science on it. So whether you think that you can intubate as slickly or drip a patient as slickly as when you were 40, and you're now getting to that magic retirement age, there are litigation issues, sadly. And then I'd like to look at the individual anaesthetist, technical skills, non-technical skills, and well-being, and what is being done in various parts of the world. So the workforce issues are very real. There's an increased demand for anesthesiologists worldwide and a decreased supply. And I know that you said that Philip has a queue outside his door of applicants for registrar posts, but I know a lot of other departments in our country at least have vacant posts and are looking for trainees. And there's no question that for some reason our specialty is not one that's being queued up to follow, and it saddens me. The other aspect is the demand for anesthesiologists is growing worldwide, and more procedures are being done, remote anesthesia cases, radiology, everybody's going into interventional work, etc., and there's a huge demand for our services. And yeah, I guess we need to start working on the recruitment of trainees. But a lot of the older anaesthetists will stay on, first of all, because you want to feel useful, you want to keep working. You've done it your whole life. In fact, I was telling somebody over the weekend now that on the 1st of July, just gone, it was 45 years since I got my reg post at Barra. So, it's who you are. For a lot of us, anesthesia is what defines us. And it's important for us to attract people to our specialty. Now, what are the patient safety issues? And is there increased litigation with older anaesthetists? And there's a publication not that recent. In fact, it's March 2012, where the Canadians, it was a study done on Canadian anaesthetists, performed on Canadian anaesthetists, and it was found that they have 1.5 times the risk of litigation against them after adjusting for the number of cases that they do, and the degree of injury has a higher severity. So that is illustrated here. And if you have a look, so us oldies are in the green. So there are less of us. We do less cases. And if here it looks like we don't have that many litigations, but if you adjust it for the number of cases performed, if you have a look, we up here in the green. So there's definitely an issue. Now, what about the individual anaesthetist? And as I say, for me, anesthesia is what has defined me or part of me for many, many years. And, are we going to have to undergo revalidation? Do we have to do simulation? Are we still okay technically? And everybody's very sensitive about it. Older anaesthetists are very sensitive about it. And as Janneke Miller-Nelson said to me when I fetched her from the airport, she said there's a lot of ageism around. And ageism is discrimination against oldies. So, and it's in the anesthetic literature. So there is a stigma, and there is ageism. There's no question about it. But in the States, I know they've suggested that either via simulation or some form of exams, older anaesthetists, over 60, over 65, depends on the state you're in, should be tested. Technical skills should be tested. I'm not quite sure how one would go about it, because we all have our own way of doing things. The longer you do anesthesia, the more you develop your skills, your skill set for yourself and what you do. So I'm not quite sure how it would be tested. There's quite a lot written on simulation, the role of simulation, and should those above 60 or 65 be tested via simulation, their technical skills tested. And then there's continuous professional development, CPD. And one of my jobs that I do post-retirement is I'm on the medical and dental board of the HPCSA, and the general countrywide doctor compliance with CPD is a dismal 23%. Our chairman, 23% is our CPD compliance countrywide for the South Africans here, which is dismal. And so I think there's an attitude of, I don't need to read, I don't have time to read, and I don't know if the HPCSA, I know there was talk a few years ago of introducing recertification. I think it would be a very costly exercise, but it may well be something in the future that HPCSA or SASA or one of our overarching bodies will introduce. Non-technical skills for me are quite important, and it's quite interesting. There was an article in Anesthesiologist from 30 years ago, and I've had this article forever. I was asked to give a lecture on the aging obstetrician at the Menopause Congress about 12, 15 years ago, And the whole front row was all the ex-retired profs from ONG at Wits. And I found this article on hearing and anaesthetists, and it's fascinating, and it's 30 years old. But hearing loss, you know when you can't see and those vocal cords are far away because your arms aren't long enough. But hearing loss is very insidious, and it's actually quite scary. And this article in Anesthesiologist by Wallace et al. Found that most anaesthetists over 40 had some degree of impaired hearing. And if you say, no, not me, go and have your hearing tested. You laugh. Yeah, but it's true. I went and had my hearing tested. I'm not as deaf as my husband, but that's not a yardstick. So, and as you can see, 80% of anaesthetists over 45 had an abnormal audiogram. Over 45, that's not even in the older group. And the big problem is that hearing impaired anaesthetists aren't aware that they can't hear, because how are you going to know you can't hear? And 39% of those over 65 who they tested couldn't hear alarms, their machine alarms. And that is very, very scary. And they looked at various factors in the theatre that may interfere with hearing, loud music. You know, these surgeons who come in with their whole music set and want to play music in theatre and whatever. And also the number of people and the general noise in a theatre will affect hearing, etc. But I think it behoves us all, in the wellness context, if you're over 45, go and have a hearing test. And go even every 5 years, but go and have a hearing test. You'd be amazed what you might discover. As I said, vision, you can realize that you can't see so well. And then what about the cognitive issues? Because those are very real for all of us, and any of us who've had aging parents, parents who develop dementia, members of our family. One is very, very aware of cognitive issues. And then there's the behavioral, personality, and substance abuse issues. So cognitive and behavioral and personality issues are very difficult. I mean, as Sue Nicol, who's chairman of our WFSA Wellness Committee, says, who's going to be the one to have the difficult conversation? So you've changed personality, or you're acting weird, or, there's something different in behavior. Who's going to be the one to say to you, can we go for a cup of coffee? Things don't look good with you. And that's the difficult one. And I think there we need colleagues and peer observation to somehow play a role, because there are no real screening tools. But the difficult conversation is who initiates that. And then there's the whole issue, which I'm not going to address at all, of substance abuse. It's often very, very subtle. Fentanyl abusers, it took us a year in my department to make a diagnosis. You confront, and eventually, yes, that's why I've been abusing fentanyl. That's why my patients writhe around in recovery. But so impairment is it sounds easy to pick up, but it's not always easy to pick up. But we have channels for that, and SASA is being proactive in our impairment program. But these other issues of behavioral, personality, and cognitive issues are difficult. I found a fascinating, it's not even a study, it was a survey, also from 30 years ago, where Ellison Pierce was the president of the American Patient Safety Foundation. And he sent out a survey to, I think it was 100 anesthesiologists in America. And the results would probably be the same today. He said, does your group have any policy regarding increasing age and changing responsibilities for the anesthesiologist? And a quarter said yes, and 3/4 said no. If no, does that infer that all members, regardless of age, share equal responsibility and income? And it was sort of 60%, 23%, and not applicable for almost 20%. And he then probed weekend work, after hours work, etc., and only just under half had fewer weekends and nights. Only a quarter did less challenging cases. And the same with trauma, open heart, complex cases, and very few had less stressful environments, and then of course there's 48% who had no answer. And then he asked the question, if you have less clinical work, what do you do? Because nobody wants to sit at home. I can promise you that. You do not want to sit at home and do very little. And it was quite interesting because 12% had administrative tasks, administrative duties, 12% were involved in pre-op clinic, 2% got involved in the pain clinic, there were consults, quite a few did teaching, peer review, but a lot of the responses, they said nothing. And obviously part of the problem is finance as well, and for those who were in the wellness session this morning was the whole issue of financial planning, etc. So money's interwoven into aging and getting to the end of one's career, but it's not the be-all and end-all. And then, do you have a policy regarding mandatory retirement age? And only 20% said yes, and 80% said no. So I don't know how different it would be now. I mean, our state says this is the age you will retire, and a lot of people leave and go into private practice. So that's a very individual, personal decision. And perhaps as a society, we should, as part of our wellness, say, you know, here are some suggested other areas where you might like to focus. And so what are the solutions? Because there is ageism, and I can tell you on my last day at Barrow, having been in anesthesia at that stage for 39 years, I cried all the way from Baragwanath to the Vaal River where I live, and that's 80 k's. And I woke up the next morning on the 1st of August, and I thought, I don't have a job. Here I am. I've got hobbies, lots of hobbies, but they don't necessarily use my brain. And I thought, sure, this is dreadful. And you pick yourself up and you think, okay, what can I be doing? So I think it's important that we guide people who are interested. Some people don't want to know. Don't tell me, you know, I don't want to know. But for those who are interested, it might be worthwhile as an anesthetic community to say, look, here are other options. We need people who will mentor. We need people to assist with wellness. We need people, as Janneke said, for everybody has an adverse event, we need people to be on a committee to debrief, I know it's the wrong word, but, to debrief and defuse situations, etc., to handle families, etc. So there's a huge number of roles that us more experienced anaesthetists could probably play in other people's anaesthetic careers. The other thing is employment arrangement for seniors, and I've always had a fascination, as I said at the beginning, in fatigue. and the effects of fatigue. And the AGBI produced this amazing document because of that young resident who wrote himself off on the way home post-call. And that triggered a whole chain of events on fatigue. And it's suggested in the literature, and this comes from Current Opinion from 2016, it is suggested that between 60 and 64, no on-calls, don't do any more on-calls. And 65 to 69, no high acuity cases, no complex anesthesia, and over 70, full retirement from operating room clinical practice, but teach, admin, do stuff. I'm almost done. Thank you. Get involved in other things. And I read this thing on fatigue probably 15 years ago when I was at Barra, and I said to I had a 2RC and a 3RC, and we sat down and I said, we should stop people over 60 doing night calls. You can't do that. And why do you want to do that? I said, because I can see you guys who are doing night calls take 3 days to recover from your night call. And it was met with quite a lot of resistance, but eventually it became the norm. And one of them who gave me the biggest flack, and those of you who know my Barrow department when I was there, you can guess who it was. Clover's laughing, yeah. And he came to me, he said, Chris, you're right. I'm a different person now that I'm not doing night calls. The Royal College has suggested similarly, they've suggested that older elderly anaesthetists be respected, valued and retained, but no night calls, work-life balance, avoid fatigue, be aware of people's financial concerns and adjust their clinical practice. And the AGBI have got a fabulous document, and they recommend similarly to the Royal College, but they've said be aware that there may be competence issues, there may be psychological issues, and there may be other issues. And perhaps one needs to have institutionalized winding down of, guidelines for winding down one's career. But this AGBI document said older workers must not become yet another lost tribe. So in conclusion, are there advantages to being an older anaesthetist or an elderly anaesthetist? And yes, if the aging is healthy, we've got experience, which has been defined as a double-edged sword, efficient diagnostic skill involving pattern recognition versus age-related decline in analytical thinking and skills. We do have insight, wisdom, and maturity, I'd like to think. Not all of us age at the same pace, and I think we need self-awareness of ourselves, but honest colleagues who are going to have that difficult conversation and gradually wind yourself down to full retirement. Thank you.
Sorry, Prof, that I was rushing you. Thank you very much. Our next speaker is Dr. Mantoa Mokachane. Is a pediatrician with a PhD in health science education, and we'll be hearing about bullying on the clinical platform from her today. So currently she's the director of the undergraduate medical education at the University of the Witwatersrand, with an interest in medical education is social justices employing an African lens, Ubuntu, in professionalism and professional identity formation. So thank you very much for joining us, and we're very excited to hear what you have to share with us today.
Good afternoon, and thank you very much for inviting me here. Yes, I was given this difficult topic to talk about what happens in the clinical platform. How do your slides go? Okay. They're refusing to go. There. I don't know how I need to press. That's the outline of my talk. We won't talk much about that. So student bullying is a global problem. It's not just in South Africa. It's highly prevalent all over. It's underreported because the students are usually scared to report the issues of bullying. And the frequent perpetrators are consultants in most spaces. And here we're highlighting the growing concern of bullying in clinical environment at universities, where future healthcare professionals are being trained. It's been defined as mistreatment, either intentional or unintentional, which occurs when behavior shows disrespect for the dignity of others and unreasonably interfering with the learning process. Examples of these are sexual harassment, which is quite frequent, discrimination, or harassment based on race, religion, ethnicity, gender, or sexual orientation. Sometimes people are humiliated, and there's also psychological and physical punishment. And sometimes consultants use grading to actually try and punish someone who maybe was asking too many questions. This comes up because of power imbalances. The clinical space is very hierarchical. Juniors are always seen as being at the bottom of the pit, and the senior consultants are the gods. They know what they're doing, and you can't ask any questions. It is a high-pressure environment. The students want to pass because families also want them to qualify and become doctors. So they're highly stressed, and usually this leads to frustration and sometimes may manifest as bullying. Even students can bully other students. Sometimes it's cultural norms where some departments bullying is used or is normalized because they're trying to toughen you up. In this article, the title is, if you can't make it, you are not tough enough to do medicine. And it was a qualitative study in Sydney. So mistreatment continues in the clinical space. And these have negative consequences to the students. Verbal abuse is used, and this is taken as rite of passage. And there's also sexist and racist behaviors. As we've mentioned, consultants are at the top of the list of those that are actually abusing this. And we need policy against bullying in almost every institution that we are in, but most of the time people are scared to report anyway. And we need to support students that are being bullied and make sure that things are done right. In South African universities, what we see is academic bullying, pressure from senior staff, including unfair grading and exclusion from learning opportunities. There's also workplace bullying, harassment during clinical rotations, being assigned excessive tasks, or facing constant criticism. Whatever you do is never right. There's also peer bullying from other students as well. This is the study that was done at WITS looking at bullying in the academic space or with academics. And it showed that if you're a female, as well as being jointly appointed in the clinical space and the university, there's a higher chance of you being bullied. And it was quite a large number of those people that were quite bullied during this period. And this was a study done in Stellenbosch where medical students showed experiences of being mistreated by clinicians and academics. And in that study, students' mistreatment is more highly prevalent among medical students, and it was a study that was conducted 20 years after apartheid has been abolished, but there were still a lot of issues around discrimination, racial issues, language issues, and gender discrimination. And there was also another study done in UCT where there was also a high prevalence of bullying, about 87%. Certain types of bullying were more common in females as well as being black. So those were the ones that were more impacted by bullying. Consultants and registrars were reported to bully students more frequently than nurses did. Negative emotions relating to demographic bullying was also found in this study. There was systematized bullying within specific departments, which according to the students are repetitive and expected. You already know when you're going into that department that you might be bullied. And there's also a feeling of academic pressure and fear associated with bullying when going into those departments. For my PhD, I then looked at professionalism and professional identity formation, but I was then asking from students to tell me about their journey through the clinical space at WITS. So it was students that were in first to fourth years of their medical training in 2015 when we had the Fees Must Fall protests. So I conducted this study in 2020. It was a combination of autoethnography as well as phenomenology. I studied medicine at WITS during apartheid. And this is when I was a young person a long time ago. And I faced intersections of race, gender, and disability that were outplayed all the time as a doctor. Firstly, in an ageist way, as a doctor, where people would be looking at me as a female with a disability and already judging me. And also in another time when it was in a racist way. I remember, I think Chris Hani had just died and I was a senior registrar. And a couple came in with a child who was in coma. It was diabetic ketoacidosis. And the father refused for me to touch the baby and said, "You can't touch my baby, you are black." And it was only my intern, who was the only white person in the room, that was allowed to touch the patient. But the intern I don't know how she did that. It may have been wrong for the patient, but what she did, she poked the patient everywhere who was in coma, and then came out to the parents and said, "I can't do it, she's the expert in here. You'll have to allow her to do it." It was only then that the parents allowed me to actually look at their child. The child did well and was discharged. But also I only started having dreadlocks after I qualified as a pediatrician, because I knew that before that I was not going to actually end up qualifying because I was going to be judged for that hairstyle. So in this study I had 13 participants, 5 of whom were graduates and 8 were students. But in this presentation, I'm just going to concentrate on the graduates. There were 5 of them, and the names I've given them there is actually part of the analysis as well. So I chose these names because they actually spoke about what these participants were telling me with their experiences in the clinical space. Using these pseudonyms, Zonaka was the woman in the group, and the only one in that group, is a traditional African name meaning beautiful. She had dreadlocks, and she would always be challenged by the nurses, by the doctors, that her hairstyle is not appropriate for medicine, and sometimes she would be mistreated because of that. But that means beautiful in Tshivenda. So she was not going to change her hairstyle for anything. And the nurses would be telling her that, you know, there's Dr. So-and-so is unmarried, and they'll never look at you because of your hairstyle and your nose ring. And when it comes to Peter, I named him the Rock. He was a white student that actually associated more with black students during Fees Must Fall, or during his training. And he had an unconventional hairstyle as well, a hairstyle that was not liked by the consultants in the wards. Asina Mali was a student who was in the missing middle during the Fees Must Fall, and his parents were teachers. He couldn't afford fees, but the government couldn't actually give him money as well. And Nyakalo means joy, and Mwizeki is an activist who was quite active during Fees Must Fall, but became silent in the clinical space because he was afraid of being victimized. So Zonaka would be told that your nose ring is actually interfering with your beauty. And they would be saying to her, why do you have dreads? Why don't you just have a weave? To them, a weave is superior to having natural hair. Peter, on the other hand, grappled with issues of race during that period. He was saying racism, sexism, students' experience in the clinical space was an everyday thing. During ward rounds, when they are being taught, they'll be singled out because of their race or their gender. So that's Asina Mali there. I'll skip that. Nyakallo, on the other hand, he suffered from racism as well. He was an activist in the forefront during Fees Must Fall. And there was a tendency of consultants not even using their names. They would be actually just using the clothing that they are wearing. Say, hey, student in a blue shirt, tell us, despite him wearing a name tag. And that was happening quite often. And also, professionalism was then weaponized against him because he was being told that during Fees Must Fall, he was actually taking the learning of the students who paid away from them by being very active in Fees Must Fall. Mwizeki, on the other hand, told us that he thinks there's a generational gap because the older generation, and maybe as Prof has just said, we look at the younger ones in a different way. We say, but we used not to do it this way. Why are you doing it that way? So they're saying there's that generational gap, and we need to actually give them room to be who they are. They shouldn't be like us. They are a newer generation. So these participants, the 5 of them, were quite transgressive in trying to show who they are, to show us their identity, and not just follow the rules that were being there. But in the clinical space, their identities were being muted by us as clinicians or teachers. Consequences for these actions lead to mental health issues. There's increased risk of burnout, as already been mentioned, anxiety, depression, and decrease in self-confidence. It also impacts on their academic performance and has negative influence on their communication skills or even their development. So we need to have education around this and awareness, as well as workshops and mentorship programs where people can be mentored and guided. But there needs to be reporting systems. But the problem is, how do you report? I usually teach students ethics, and we make examples of the surgeon in theater who will be playing loud music with profanities, and I ask the students whether they'll actually question that, and all of them would say, no, I can't. I'll keep quiet because the nurses and the anesthetists in the room are not saying anything. Why should I be saying anything? I'm the smallest or the youngest person in the room. But the sad thing is that when I meet with them during internship, they are still not able to talk. As registrars, they are still not able to talk. So it doesn't stop. You won't say, I'm not doing it because I won't get my credits, but it carries on forever. It stays with you. You are not able to actually question things that you are supposed to be questioning. So we need to create a positive learning environment. We should encourage teamwork among students, professors, and clinicians. Leadership should be accountable, and I'm glad you raised how leaders should be behaving. We really need to be taking care of the students as well as those that are taking care of the students and patients. And we need to continuously evaluate if there are issues in our institutions around bullying. Thank you very much, Galebo.
Thank you very much, Memandwa. I'm pretty sure there'll be lots of questions and comments to your brilliant talk. We'll keep those until the end. Now, I'm going to welcome to the stage Dr. Jannica Melin Olsen. She's an anesthesiologist from Bærum Hospital in Oslo, Norway, and she's also the immediate past president of WFSA. I think that's how we would remember her, most of us. So she didn't put much in terms of her bio, but I've just found out that in September 2021, the King of Norway appointed her as Knight First Class of the Order of St. Olaf, which I thought was quite nice. Welcome, and we're looking forward to your talk.
Well, thank you. There has been said so much important now, so I had plenty of comments, but I will try to keep to my topic now for the next 20 minutes, and that is what to do when things go wrong. That's very closely interrelated with the topics we have heard, although we are mostly talking about relationship to the relatives and patients now. Here are my disclosures of interest. The only place who pays me money is my hospital, and they don't pay me so much. When it comes to medical disasters or untoward events or accidents or disasters or what, they can happen anywhere and anytime with any of us. We heard some examples of that, of syringe swaps. I might come back to that as well. And I'm going to share with you a case report from my own hospital a long time ago. It was a 74-year-old lady with a subarachnoid hemorrhage after surgery. She had been transferred from the university hospital after 1 week. It was a Thursday, and we should just wake her up on a ventilator and then extubate her and fine. So this was a Saturday. The ventilator settings were very minimum. She swallowed, opened the eyes, and there was a trainee, quite experienced, but she was taking care of that case in ICU, whereas I was busy in the next room with a limitation of intensive care. I mean, a patient who was about to die, so I was very occupied with that patient and the relatives. So then, okay, what's the worst thing that can happen? She took out the tube, and we thought it could be good to take it back. Everything had been prepared, the emergency kit, and we were prepared to intubate her again, or she was. Well, then there was stridor, no effect, and you can imagine what happened. She tried to re-intubate, it didn't work, couldn't see anything. I took over, no view, blind intubation, obviously esophagus, laryngeal mask next, could not ventilate, and then you push on the button. And then she had been given Saxa, and we thought it might be a reaction to that, so she was given adrenaline. Now everybody comes to the place, and everybody's doing their things, and you can see what happened, bradycardia, atropine. The surgeon attempted to do emergency track, fails, and then it was subcutaneous, so suddenly it was this Michelin neck, and cardiac arrest compressions, and several intubation attempts, and then two doctors could hear chest sounds, but I had a bad feeling, although the saturation increased. And then after 1 hour, it was clear this was end of the game. And we had the impression we had done the things according to the plan, but it didn't work. So now we were there like featherless birds. All that adrenaline, suddenly, you know that feeling, the patient is dead, what do you do then? Well, you have to take care of the patient, the relatives, and ourselves. And the way you do that will make a big difference. This is a colleague who said to the parents when he had refused to do a C-section even though they had agreed, and a baby died, he said to the parents, well, this was my fault, I am deeply sorry, and they asked him to deliver their next babies after that. He did it well. How can you do it in a good way? Well, at that time, what you do, you are just in, distress, and you need some guidance. And I was very lucky. I was the editor of our national journal of anesthesiology, and we had a Swiss, Sven Stander, just given this talk on our annual meeting, and I had asked him if I could publish it. And after I turned around, I saw that edition on the shelf, and I could go up there and follow the advice from A to Z. And that is the first thing you are to do. If the patient is alive, continue the treatment, initially the same team, and call for help so maybe somebody can take over, and then delegate. And then the treatment team should be relieved and been able to take a rest and talk about it. And after the whole case was managed in a good way, I will come back to some more details. I tried to, every time something like that happened in my hospital, I said, read this article. They never did, but finally I got the national authorities to produce guidelines, which was launched last month, and they will be available in English. Only the summary is available in English now, where we have about how to care for everybody. And the first part is for patient and relatives. Okay, the first thing we have to do is, of course, to document and take all the relevant details. But here we should not interpret what has happened and we should just write down exactly what kind of judgments we made, and then not all the interpretation. But then, in addition, it is advised that you write on the side your personal notes with all the details, because memory is a weak thing. So it may change when you start to talk about it to other people. And then, of course, report to relevant authorities. Now we have to come to care for the team and the individual afterwards. We talked about part of this was in the previous talk, so I'm not going deeply into that. But all of these people have to be involved, and it's very much a leadership thing and a culture thing. So here is the advice they give that you should inform the patient in person and not by phone. Well, I called the son and I said, okay, there's been this thing, it's a serious thing. They say I should not tell the worst news on the phone, but I felt I had to tell him that his mother was dead. Then they came, all of them, to the hospital. I met them myself. That's often a good thing if you are able to do it. At least you should be part of the process. But if not, you could have a senior person, possibly your leader, when you explain. And then the worst news first, and then again explain the facts. Because at that sense, what happened really? And you can think aloud just to figure out why this happened. But that's not a good idea, because they will be like sponges. So if you have a loose theory, they may think that you are giving them the final decision, and that might lead very, very bad. And then, if relevant, prognosis, and at least what will happen now? Don't blame anyone. That's typical. I don't understand, how could that surgeon do that thing? This is very natural and human, that we want to put the blame on others. Not a good thing. And for them, you are a representative for the hospital, the system, so it doesn't help much. But all through what you are doing with the relatives or the patient, be empathic. I mean, show them that you care about them. And as I said before, you should not be the one who cries the most, but that you are able to tell them that you really care about it. It's not something you take lightly. full investigation, describe the process, and tell them, when will you hear from us again? Because sometimes you will say you have sent this to authorities for investigation, and you will hear more. But then if they don't hear, in the old days, in this time, there was the mailbox, and people go to the mailbox, empty. Tomorrow, empty. After a while, when they don't hear anything, they will get angry. So agree on point of contacts, and then you call them, and you tell them, well, I don't have more information, but I will call you again next week or after 1 month or so. Don't shy away, because after a while, this was what happened in this instance. After a while, it was like the relatives and I were on a common trail to find out what happened really and what could we learn from these things. And keep those appointments. That part of the analysis, I'm not going into detail, but that's very important. If you see patients going to the newspaper, nobody wants to see their loved ones on the front paper of the newspaper. It's an act of desperation, in a way. So if you take them seriously and follow them, and they don't have to go to the mailbox and go to the newspaper, then that's the best thing we can do. And everybody who goes to the newspaper, at least in my experience, say, well, I do this because I want, if this can prevent that anyone else experiences our loss, it's worth it. That's what they say. I know we have discussed in the previous about openness, because that's another big problem, that we don't tell the truth, we try to hide the truth. And that is very, very dangerous. The Australian Open Disclosure Framework several years ago, I think they've changed it now, unfortunately, because this is a very wise advice. Imagine the last time something went really, really wrong. Imagine that it concerned you, your wife, or your relative. Imagine the conversation you would have wanted to have with the doctor, the team, and the management. I mean, we would like to learn what has happened. And what is the open disclosure? Empathy, as I mentioned, facts are told, what's the consequences, how do we handle the incident, and very important, how do we prevent that it can happen again? And that is often felt as a relief for involved health personnel. Here is an example where this didn't happen. It's in the US, Justine Michalizzi. He was an 11-year-old going in to drain a swollen ankle, and his parents never saw him alive again. And what happened? They just could not know. They tried for years and years and years to find out what had happened, and absolutely impossible. Until after 10 years, the mother gets a letter from one of the doctors who had been involved. I have seen your pain, I have seen how hard you have tried to find out what happened. I didn't have anything to do with the case, but I know what happened. There was a syringe swap. He was given phenylephrine instead of fentanyl. And if you look at those, you can understand. So he had this very high blood pressure we heard about in a previous talk, and he died. And what she said after that, what a relief to finally understand what happened. You see, parents want to protect their children, and when you cannot do it, you feel like a failure. What a relief for me to hear what finally happened. And here's another from Norway. That was a colleague of ours who was brought into the hospital, and he was intubated in emergency, and the tube was displaced, and they were working on it, and they agreed afterwards, we are not telling, we are not reporting this. So the family didn't get to know the truth. And then, of course, it's a small town, and people talk. He was a colleague, so we were all in health, or they were all in the same environment. And then they heard something. And finally, after several years, this was reported and investigated by the authorities. And then when it came out, the report that it was an error from the side of the hospital. This guy, 15 years old, he had for 3 years thought that he was a reason to blame for his father's death because he couldn't remember the number 911. Imagine what that immense stress for a teenager. And we have all of those, barriers to openness. I see time is running, so I'm not going into all of them because we know them, you can read them for yourself. But the thing is, one of the major things is fear of litigation. And this is a very old study, of course, but it's still very relevant because the expectations why these people went to litigate was, so it should never happen again. I wanted an explanation. I wanted the doctors to realize what they had done. This is just normal human behavior, how to take care of each other. They didn't want money or revenge or anything. They wanted to know what happened. And they said afterwards, what could have prevented the litigation? Explanation and apology is what most of them said. Explanation and apology. And then you think, this is from the UK, of course, many years ago, and I told about Norway. Oh, that's such a nice place. But then this is from the United States at MedStar Health, where they have installed the candor process after medical errors. And that candor has 7 pillars, as you can see here. Incident reporting, when there has been an error. Investigate while holding hospital bills. They do the communication I have spoken about. Full disclosure, apology, and rapid remedy if appropriate. And then continue with tracking the data and educate and training. So this was in the infamous country of medical litigation, United States. And what happened? There was an increase in reporting, 27-fold increase in event reviews, and look at the reduction of serious safety events. And then more than half of decrease of the total medical liability costs, and almost half, 50% less lawsuits. So this is important. So let's say the investigation after there has been an event shows that there was really not a medical error. Still, empathy, trying still to support those patients and follow up if there has been an adverse event which really nobody could be blamed for. But if there has been a medical error, the apology, the power of apology cannot be underestimated. And that is okay, as I've shown, if you remember, after my speed talk about this obstetrician. This was my mistake. I should have listened to you. I should have given you the C-section. And so describe what happened and admit from the hospital that this was our responsibility, and we are really, really sorry for this. And this will lead to this type of changes and in behavior and practice. So a sincere apology that they understand that you really mean it. Because this is how it's being done. I showed that more or less in the previous slide. But there are some other apologies, like, well, I'm sorry if you feel I have done a mistake. I'm sorry if you feel this and that. That's a pseudo-apology, which is worse than saying nothing. Or to just explain why we did without really apologizing or regretting. And then if they feel that this is something you are forced to do, you don't mean it from your heart, and you feel it's a formality. I mean, it has to be perceived as genuine. And then I mentioned this in a talk earlier today about taking care of staff, but it's the same from how can good caretaking contribute to learning from adverse events. Because if you are open, you will get more facts on the table, And you can also include patient and relatives in how to deal with it to avoid for the learning process. And that shows healing for patients and relatives if they can contribute for the future. There are numerous studies on that, which I don't have time to go into. But it's the patients and relatives are experts on the condition of the patient. So they are a resource for us, should not be a threat in an optimal world. So I go back to my case. We did the immediate debriefing or defusing or whatever. So I assembled the team. I saw that the scrub nurse should understand why I had done this and that and pushed here, so that everyone, when we left that room, they knew why things had happened when they had happened. Otherwise, we would have 10 different stories spreading around in the hospital. And I've seen examples of that when that hasn't happened, that one department is, the anesthetic department, they are just stupid. And we would say the same about the medical department. But if you have the same understanding, we can avoid some of that. Documentation, we did that. I phoned, as I said, I phoned the department, I reported, and then the following day, of course I didn't sleep much that night, but the following day I went with them and the grandchildren to the morgue to see the grandmother with her enormous head and neck after the subcutaneous emphysema. And I mean, I met them and saw them in their eyes. It was not the nicest thing I have done, but it's one of the smartest things I've done, also for my own healing. I contacted them every week for 1 year, more or less, while I followed it through the forensic, I'm soon done regarding time. And for 1 year, and I felt that we understood each other in a way after that. And then they said the anti-E levels were very high concerning Saxa, but I knew what had happened, and because I think it was edema after having an ETT in for a week, and she had edema, and that's why. I think that was the reason. And then the forensic commission, the chair of that, he called me and said, Jannike, I know everything has been cleared all the way, and I know that the patient had so serious brain damages that she would probably not make it. But we cannot say that she would not have died at that time if you had not, or the trainee had not removed the ETT at that time. And I said, I know that. But for me, all of that I was able to deal with that case in a good way with the relatives have helped me. And then what about the trainee who did it? Because I was wondering for years, I thought, had she forgotten the whole thing? Because she was just, and then I met her again after 15 years, and I said, do you remember? Oh, yes, I remember. How are you? And then she said, well, I remember you taking everything from that, and that has really been important for me in my career, to see, according just what you said in your talk, that the older colleagues, and you have said also, take responsibility. So for the summary, patient relatives, openness, 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 involved health personnel, support, 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 authorities, report, report, report. I know that this is not what I have said, is not fully applicable all over, but the principles are the same, human beings are the same. And I'm looking forward to seeing you in Marrakesh. Thank you.
Thank you very much. That was amazing. We're really spoilt in this session today with anesthetic royalty. Really, we've had some amazing speakers here, including you, Prof. Chris. And it is a huge privilege for me to introduce our next speaker. It's Prof. Arthur Rantloane. He's got a number of roles that he's played, but most recently he's the retired Dean of the Health Sciences Faculty at the University of Pretoria. And he's also the former president of SASA and the African regional section of WIFSA and the College of Anaesthetists of the CMSA. So we really are spoiled today, and Prof is going to talk about reintegration of impaired practitioners. Thank you.
Thank you very much and good afternoon. Can I just get a sense before I share my thoughts with you, if anyone knows of a colleague who is hypertensive and is receiving treatment for their hypertension? Anyone know? Okay, thank you. Does anyone know of a colleague who is suffering from substance abuse and is receiving treatment or has received treatment for it? Oh, okay, okay. No, thank you very much. And that's important because as you'll see, as you go to the end, and I think it's actually quite good that Philip spoke before me because, and in fact, to be frank, in the speakers who came before me, what seemed to be a central theme was the idea of compassion, which is going to really be the punchline of my talk to you today. So my purpose here is to talk about reintegration of impaired practitioners. I just there have given you some sense of what impairment looks like. I intend to concentrate on those practitioners who are impaired because of use of chemical substances, acquired impairment from chemical substances, and not the others. And that is because the others are fairly easy, fairly straightforward to deal with. The difficulty that we have is with the individuals who use substances that we use in the operating theater. So, why does this come about? So at the heart of this discussion is a publication that some of you may be aware of. This is the publication that set the cat among the pigeons. And I think it is important to just recall how this publication came to be. So after various anecdotal reports of anesthetists dying from overdose, using the drugs that they use in the operating theater, and allegations that some patients were harmed in the process, then some people undertook a study to try and quantify this problem. So what they really did was to call up heads of departments, program directors they call them, this is an American study, and ask them about the registrars who had been in training, who had suffered substance abuse, who had been removed from training and come back after rehabilitation, and they wanted to know what were their outcomes. And the result of that survey is what you see there. This alarming report that they have there. A third of those residents or registrars, only a third were successful upon return to training in anesthesiology. But those who had not been abusing opioids had a 70% success rate of rehabilitation. But I think one of the key findings there is about the mortality from substance use in this cohort of registrars. And because of this shocking, these alarming figures, not surprisingly, the conclusion and recommendation was that those individuals who use parenteral opioids are likely going to harm themselves and perhaps even harm patients, so they must not be returned to training. So I thought with that as background, maybe to also just walk you through some of the publications that then came up after that one. Because following this, departments then introduced programs for education, for awareness, the protocols that were established to manage drugs of abuse, and then, but it also ignited research to try and understand this problem better. And what I've got is a selection of publications on the subject. But this was done intentionally because these are the most cited references on the subject. And these were bunched together because they all were in favor of not allowing anesthetists back to the operating theater if they'd been using opioids. And in particular, if you look at that list, if you look at the last two, Bryson and Silverstein, and then Berge et al., you will not read even a recent publication on substance abuse, and there is no reference to those two researchers or authors. On the right there, you see the recommendations from each of those studies, and to the last one, all of them recommend keeping these people out of the operating theater because they will harm themselves and they will harm patients. And what I'd like to do with the next lot of publications that I want to discuss with you is to try and confirm if indeed anesthetists who use these substances will harm themselves because they relapse and whether they will harm patients. What I've highlighted in red there is just to show that following, upon reflection, even these two groups of authors, Bryson and Berge and al., recanted and grudgingly accepted that you can't keep, in all conscience, you can't keep these people out of theater, provided there are safeguards around their practice, it is okay to send them back to theater. This is a more recent publication about whether anesthetists, such as I've described, who have been who've got substance use disorder, who have undergone a rehabilitation program, if indeed they pose a greater risk to patients. And I think in general you can see, compared to other specialties who also use the same substances, similar relapse rates, similar mortality rates, similar disciplinary rates. So non-compliance was the same across a whole range of specialties and not a feature just of anesthesia. So this is again just a selection of publications, again, fairly widely quoted, that seemed to see a different picture to the first lot that I presented. And I won't go through each one of them, but I think the striking thing that you will see between this lot and the previous lot is that if you look at the outcomes that are being reported, you have much lower mortality, you have much greater success in those individuals who underwent treatment programs and were allowed back to theater. I think I'll talk about the Domino study of 2005 a little later, but I think this actually, I think, was the game changer in how the anesthesia, in fact, not just anesthesia community, but in how the medical community viewed substance abuse and whether rehabilitated impaired doctors could go back to service, be it in anesthesia or in any other capacity. This then these are the results of the study that was done by Domino. Now, two critical things about it is that this is data that was obtained from a well-structured, well-resourced, established physician health program in the US, the Washington PHP, and this looked at data over a 5-year period, in fact 5 years and more, of individuals who'd entered the program, who'd left the program because of the substance addiction, who'd undergone rehabilitation, and would come back into practice and what their outcome is. Now, what this group wanted to do was to try and establish if there are any risk factors, who is at risk of relapsing if they've been using these substances, they've been rehabilitated, and they go back to the operating theater. And these are the key findings. The risk of relapse, if you compare this to individuals who are not using a major opioid, the risk of relapse doubles when you are using a major opioid, when you also have a diagnosis, what's called a dual diagnosis. So if you've got an underlying psychiatric diagnosis, depression, bipolar mood disorder, those kind of psychiatric illnesses. So underlying psychiatric disorder or a family history of substance use disorder, the risk of relapse almost doubles. Then they also indicate, I mean, I think it's also intuitive, if you've got all those, so if using a major opioid, you've got a family history, you've got a psychiatric diagnosis, then the risk increases exponentially. And in fact, so there's a 13-fold increase in your risk of relapse if all three are present. But what also is of interest in their findings is that returning anesthesiologists had an increased risk of relapse. So if you take just a group of anesthetists, some are diverted to other programs and others go back to anesthesia. Those who are diverted to other programs generally do better in terms of relapsing compared to those who go back to practice. So when one looks at the available evidence in total that has driven the decision whether to allow people back to theater or not to theater, these are the shortcomings. The first lot that supported keeping people out of theater, in fact, was data that was obtained from surveys. So it was poor quality data. But if you compare that with the second lot of data, this is data that was obtained from programs, as I said, that are well-structured, that are well-resourced, that had reliable or verifiable evidence in them. So studies that described outcomes that were similar between anesthesiologists and other specialties were based on this data from physician health programs. But of course, so what actually is needed now is to try and show this association between the major opioid substance abusing person, their profile, to the treatment they undergo and their outcomes. Then that's the kind of robust evidence that you actually need. I did think that this was important to share with you as well. This was a study, the study by DuPont and colleagues is the largest by far of that followed up addicted practitioners. These individuals looked at 16 physician health programs in the US, and they followed these patients over at least a 5 to 7.5 year period. And they were interested to see what outcomes those programs produced. And just a summary of those findings, they showed a very high retention rate or success rate in those individuals who underwent the program, and only about 18% of these individuals actually left the practice. And in that discussion, they actually suggest that the intensity of the nature and intensity of the program weeded out 18% of individuals who in fact were going to relapse had they been allowed to continue in practice. Importantly also, the findings did not differ by substance of addiction. So physicians with alcohol use disorders, for instance, had similar outcomes to those with opioid use, with cocaine use, with benzodiazepines. And whether one used an IV drug of abuse or took it orally or intramuscularly made no difference. So these, in summary, are the observations. 78% out of the 73,282 tests, 78% did not show a single positive test. And what was interesting as well is that, contrary to what previous studies have suggested, that in order to manage the craving and to also prevent relapse and mortality from relapse, that people should be prescribed naltrexone. They've showed that, in fact, that actually may not be, that pharmacotherapy may not be required, that in fact it is behavior modification that achieves the outcomes that you want. So what we know is that there's a very high abstinence rate in physicians who undergo these programs, and we also know that anesthetists don't have higher relapse rates than other disciplines. And again, of interest, fentanyl is in fact not a cause of more significant relapses. I mean, the relapse rates actually tend to be lower than with other major opioids like morphine and pethidine. And then, again, I suppose this is just known that within about 2 years of the program, that's when you'll start seeing people relapse. So when one then contemplates returning people back into practice, there are some parameters that the American College of Physicians published, a framework that they published in 2019, and this is a paper that I think will be helpful to look. I've paraphrased their position statements here to describe the principles that they think will be helpful for anyone who wishes to return practitioners to theater. The first thing that they remind us that, or remind physicians, that if physicians want to self-regulate, they have to start with themselves. They have to make sure that they're able to practice safely and competently, and those are the other position statements that they actually have. So when is a physician ready for re-entry or for reintegration? And again, here we can look at work that was published by Angres some time back, 1998, in fact. So he had a whole set of criteria that they looked at, and then from there they prepared a decision matrix, and in terms of which, depending on how you scored using those criteria, you would be a good candidate for re-entry, and your chances of relapsing were quite reduced or minimal. If you're category 2, you could be returned back to theater and maybe be reassessed in 2 years. But if you're category 3, the advice was that you be redirected to another specialty. Interestingly, in the Berger paper, they suggest there that if the addiction psychiatrist is against recommending a return to theater, you should not return to theater. If you look at the guidelines of the AAGBI, they say if the individual is abusing inhalation anesthetics and propofol, they must be redirected to another specialty. Okay. So when the practitioner must go back, there are certain considerations that apply in terms of how you manage that situation. Of course, the key priority is to ensure patient safety, and non-negotiable is physician monitoring and compliance. So the environment that they go back into, you must be able to do this, and the sophistication of that monitoring is what's important. Do you do urine samples? Do you do hair and nails? But so it's going to be sophisticated. And then you must protect the rights of the physician, as opposed, and also the rights of the patient, and so on and so on. So in terms of workplace integration and peer support, the critical thing there is to manage stigma that returning physicians or anesthesiologists have to deal with, because that then impedes their reintegration. So you have to manage stigma in those things. I have here the last point, the financial implications, because just to be reminded that, excuse me, that the cost of all the testing of the program is for the pocket of the physician. It's not for the pocket of the state. And remember, this is an individual who already now has got stigma because they are known to be using substances. No one is going to give them a list. No one is going to give them, ask them to come in and locum. So it's just something that as we reintegrate them, we need to be aware of that. So the same considerations that I had on the previous slide for physicians obviously will apply, even for anesthesiologists, but I think of particular importance there is the gradual re-entry and controlled exposure, that you limit their activities as they come in, lists that are non-specialized lists that are not complex. You restrict access to substances that may be harmful to them. You always have a second person to confirm that substances that have been issued have actually been administered to patients. And lastly, every practice environment needs to develop a policy on how you will deal with individuals who have substance use disorder. And so in terms of where they want to go to, those are the sort of things that you want in place. Your selection of your selection of the candidates must be such that you are almost guaranteed that they won't relapse. They will, in fact, 25% will relapse anyway. I've talked about the depot naltrexone, and then you must have sophisticated monitoring and those other things that I've listed them. So I think in sum, what the evidence literature tells us is that yes, it is feasible for impaired practitioners who have undergone a treatment program to go back to theater under the conditions that we've described, strict re-entry criteria, strict monitoring, random testing, management of the environment, and graded entry into the work environment. And I think the last question really, I suppose, in fact, the last two questions that I think we must ponder is whether we must now develop protocols for access to propofol, because where propofol has been used or has been the substance of abuse, that's where you tend to record more deaths because of overdose. So perhaps we must consider developing protocols for propofol. And I think lastly, maybe we must rethink the idea of routine testing of staff that is exposed to these substances that we know now as substances of abuse. Thank you very much.
Prof, thank you very much for a brilliant talk on a very difficult subject. We have unfortunately gone over time, so I would like to ask everybody to give a big round of applause to all our speakers. I know there are some burning questions and comments probably that want to come from the floor, but some people need to move to other venues, so maybe afterwards. Oh, sorry, I thought somebody was talking to me. Anyway, so the message that I took from here is empathy. That's sort of been a recurring theme for all of us, and in a language that probably most of us would understand. Just be like, thank you very much, and have a good afternoon.